Okay, thank you, Ansar. So I'm just gonna share my screen there. There you go. And I'm gonna minimize all of you guys. Anyways, I was playing around with the logos there. There we go. As you've seen there, between 20 and 30 people have already joined in this morning, which is great. And there's members of all of these groups here, obviously New Brunswick Heart Centre people. So um, I want to acknowledge, though, that, looking at cardiac care in New Brunswick in general, there are certain parts that I'm not going to address because obviously while I'm going to globally address COVID-19 and its impact generally on us and all of cardiac care, I will not specifically deal with, particulars about community cardiology, interventional cardiology, and electrophysiology, which I'm sure have their pearls of wisdom of what's happened in the last few months and how they're moving forward. But largely focus on a little bit of my perspective from a CV surgery point of view, but keeping it relatively broad at the same time. So the good that's come out from the last 3 months in my mind are three major things that come first to mind. As the first is connectivity. And what I mean by that is, for example, today what we're doing is our ability to improve education, which has always been there, but we just never capitalized on it and used it. And we've improved our facility to participate in meetings. For example, there's no reason not to be in a meeting. I can be driving, I use my phone, I can always join in and participate. I think there's a huge opportunity that we're trying to build, and all of us are trying to push that, is to actually increase access rather than have decreased access for patient. And that's related to virtual care. And, certainly, every week now I do clinics, and I do clinics over the phone, and I'm trying to set it up now on Zoom since we have healthcare related Zoom. And then our ability to deal with patients on a remote basis is much easier, and patients can reach you much easier. And finally, I think we were able to demonstrate, and I'll demonstrate that to you and to us, that our ability to decrease and ramp down what we do every day and build capacity in the system to respond to a pandemic like COVID-19, we're able to demonstrate that we can do that very rapidly and very effectively. And now we've actually showing that we're able to ramp back up. So there, it does give flexibility in our system. Oh, sorry there. So the connectivity, this is an example of connectivity. There are 32 adult cardiac centers in Canada. I've been president of the society now I'm at the end of my second term, and this is the end of my term. Before the pandemic, it was exceedingly hard to get all the heart surgeons, at least the chiefs of cardiac surgery, from all these centers together. And we've been able to get them together. I actually have another conference tonight, of which more than 22 out of the 32 have responded to. So these are the kinds of things that we've been able to do that were not possible before, and this is very unique. And for example, we've made some surveys that we've tried to get from all of them, and participation is around 90%. So it's interesting how the pandemic has really narrowed and allowed people to focus on sort of things at hand. And here's some of the examples of the kind of questions that we asked. Is at the peak of the pandemic, in most places, were centers able to do elective surgery, for example? The majority of centers were not. So 75% of the centers were not, which is really what falls in. So people were building capacity. So those are the good things that I've mentioned to you about the pandemic and how it's affected us. But what about the bad? Well, the bad is clearly the patients that are impacted by COVID-19. The reality is that we've seen, at least from my point of view, from a cardiac care and my daily practice, is it's not had a huge impact in New Brunswick, clearly, with less than 200 patients affected, with very few active cases right now, very few of the ICU resources. But it's not to be I think we should be grateful that it's not been impacting us, but realizing that worldwide, it is impacting a lot of people. And I'm sure all of you have friends or people even my brother-in-law got admitted to hospital for COVID-19 in Quebec. So, this is touching all of us and touching friends of yours. And, there are more than 5 million people in the world. And I'm sure you've seen all of these types of resources that exist out there. This is just from a few days ago. If you go to Johns Hopkins Coronavirus Resource Center, you can actually follow every country, every single dashboard you can imagine. The curves are looking at case rates and mortality rates. And there are over 350,000 people that have died of COVID-19 worldwide. So this is clearly impacting the world and will likely impact us. But from a cardiac care in New Brunswick, however, the pandemic has made a lot of changes to what we do things provincially and medically, and it's probably resulted in a tremendous amount of delay in treatment and its consequences if you think of the lockdown that occurred on March 14. So how did it affect us? Well, before I do so, I sort of want to narrow a little bit our focus on trying to think of the perspective of cardiac care. The reality is COVID-related concerns, if you take away the specific things related to the virus and the heart, it really is important to imagine that cardiac patients are felt to be particularly vulnerable to the pandemic. And that also affects their psyche. Many of us are nervous about some aspects of being scared of being potentially affected by it. But can you imagine if you're a particularly vulnerable person, they may feel terrified to seek attention, and that's really important. I think cardiac surgery already had issues with wait lists prior to the pandemic. We had wait lists that were quite high. We were working very hard and trying to address them, and it was already difficult. And I'll show you that perspective. And then you add the pandemic to this that delays things and sort of cancels procedures. What happens to these patients? And then finally, cardiac surgery is very unique compared to every other service that you might imagine. 100% of our patients, except for TAVI, require ICU resources. An ICU resource was the resource that was trying to be protected in the setting of the pandemic. So there are centers in Canada and in the United States that completely shut down cardiac centers entirely for weeks on end because of their inability to provide ICU care to them. So these are the kinds of perspectives to keep in mind. So just a perspective for us is in cardiac surgery, starting in 1991 when the program started, it's been a steady incline of number of cases done. Even last year, we went above 900 cases, 916, I think, as the year of 2019. So every year we've been increasing a little bit our productivity. And in January, actually, we did 92 cases in the month of January before the pandemic. And the average for the year is around 76 per month for the 12 months if you do 900 cases. So it gives you an idea that we've been pushing hard in trying to do that. But despite that, our increased capacity, we've still had more than 150 patients on average waiting on our wait list. And sometimes it goes up to 160, sometimes down to 120. But generally speaking, we've had a tremendously hard time addressing these patients. So clearly, the demand in our province is very high. And sometimes increasing despite our efforts to try. And it's not because the population of Brunswick is increasing, or at least not sizably. So this has meant for us at the Heart Centre to really focus a lot on waitlist management strategy. And this was important to us from the outset of the pandemic. So we, from the get-go, contacted all patients. We did ask about symptoms and concerns, and we provided numbers and contact for a triage nurse to give to patients so should there be issues. We also contacted in writing to all referring physicians to inform them of their patients that are waiting for surgery for their help in terms of triaging. And the principles we were trying to get is that it's not necessarily the patients that have waited the longest that are more likely to have adverse events, but it could be any patient on the wait list. So symptoms were very important. And the feedback from our specialists was helpful in that. And particularly at-risk patients, we felt were patients with severe aortic stenosis, left main stenosis, and low EF patients. So this is what has occurred to us in cardiac surgery during the COVID pandemic. So if you look at the axis here, these are number of weeks in the year, 0 starting the first week of January. And if you look at the round dots, there's the total number of cases that are done, which includes transcatheter valve. The transcatheter valve are the triangular ones. And if you subtract the other one, the cardiac surgical cases are the black boxes. Essentially, you can see that we average, and the blue line is around 17.7 cases per week is the average that we try to aim for to achieve around 900 cases a year. And to be able to, so we're trying to hit the 18, so we're able to pass. And so every year we started to increase that capacity. And you can see that we hover up and down, mostly up for many weeks, but some weeks are obviously down. And as the pandemic started in March 14, we completely locked down and we completely decreased that capacity dramatically. And then after 4 weeks of that, or 3 weeks of that, we're able to gradually ramp back up our capacity to where we are currently, which is essentially close to what we were doing prior to pandemic. And this has been a gradual process, which is what we were hoping for. So our ability to decrease that was quite dramatic. I don't have the slide to show you, but the ICU bed capacity within 3 days was essentially, we were able to clean up ICU quite dramatically. And within a week, the ICU was essentially empty and ready for COVID-19 patients. This is really important for the pandemic. However, it did result in a case deficit. So if you calculate the number of cases you missed, if you'd use that average, there were 66 patients during that period of time that did not have surgery that normally would have surgery over a period of 5 or 6 weeks. This is a tremendous number of patients. And its impact on it is probably going to affect us for a long time. So how did it affect our wait lists and the median time that patients are waiting? So surprisingly, if you look at wait lists, our wait lists, so current patients waiting is around circles. We have, if you include TAVI patients, if you don't include TAVI patients, we're around 150 usually. If you include TAVI patients, we're around 165, 170. And it's really not changed over that period. The pandemic is in the middle here. So surprisingly, and if you look at the median wait time, it is just starting to tick up, as you might expect. So we're around 120 now. So the median wait time means that half the patients are waiting about 110 days. We are trying to aim for 42 days. So we're clearly double the median wait time that we should. And if you look here, I do have in triangle, admitted while waiting. It's actually 0 throughout the entire period of pandemic, except for a little bit later on, which I'll show you. So what do you think happened to the wait list in terms of adverse event? And this is what's important. So clearly some patients, I'm sure, have had increased symptoms. I did not look into that, and specifically because that's always difficult and subjective, as you know, because patients who complain tend to be the ones that obviously we pick out. And there may be other patients that are having more symptoms. But there were really not a lot of change. If you look at last year over the year, and if you look from January on, there were actually only 4 patients during the 8-week period that required admission for increased symptoms and that required surgery during that time. And there were no deaths on the wait list during the 8 weeks of shutdown from March 14th to now. So that's comforting in a sense, but I think it's important that this does not mean there's not an issue here. I don't want to convey the message, well, it doesn't matter, pandemic, wait, doesn't matter, you wait longer, nothing happens. The reality is the longer you wait, there will be some issues. And it also highlights the fact that we are continuing to explore as many options as possible to increase capacity, because that's important. But the reality of why the wait list did not increase over that time is probably also related to my cardiology colleagues. This is the number of consults that we see as surgeons on a weekly basis, again, as you plotted. And this is during the pandemic period. There is a period where the number of consults during a week were quite dramatically lower. And the cath lab output also during that period was much lower. So referrals, emergency room visits, and referrals from cardiology point of view were relatively low during that period of time. And that's been an observation in many other places around the world with the pandemic, is less patients came to the emergency room, less patients complained of cardiac symptoms. Doesn't mean it didn't happen. It just means they didn't show up or came probably because of scared or issues with worried about COVID-19 during that time. So implication of this at a population level is only speculative at this time. The only data that I saw that was really compelling in my mind was from New York City, looking at type A dissection rates during the period of pandemic and the dramatic drop and the associated increase of mortality during that period. It makes you think that many patients just did not show up and died at home. So what about the ugly of the crisis? So I've shown you the good, some of the bad, and what about the ugly? And the ugly is a little bit, these are the things that are terrible. And I think this is one of those terrible things that all of you have seen on the news and all of you have seen potentially impacting your family or family members. My parents in their mid-70s, and they're trying to make choices potentially for not a care home at this time, but it's certainly in sort of some living conditions that they want to see themselves in their future, and it's scaring the hell out of them. In Canada, more than 80%, I think it's actually 75% on the data from this morning, of all mortality. So there have been 6,000 or 7,000 deaths. 75% of them were related to vulnerable population in these types of homes. This is incredible. And it highlights the lack of uniformity, the lack of standards, and the for-profit potentially being part of it, and cutting corners, trying to limit. Yesterday, I think this morning on the news, they were sort of quoting out of a particular home with over 200 beds, one RN only providing, and out of some nursing homes with 30 to 50 patients, only one personal care worker to help those 50 people that are dependent. I can't imagine how possible that is. The next part for me in my mind that's been the ugly has been PPE discussions, controversy, and lack of preparedness. I mean, we still debate the mask use. There's still, you know, I personally don't want to debate it here on the talk this morning, but this is kind of sad that we can't even come to consensus in some aspects, and there are people fighting some of these issues. It's amazing how PPE availability and supply chains were so fragile that in some places people had to keep them, wash them, reuse them, and use alternatives. I mean, it's mind-boggling in my mind that we all have a cell phone, we all have a smartphone, we can do all these things online, and we have an inability to really guarantee this as something we would use. And finally, the final thing is the misinformation and confusion, and you can't but not put Trump up there to sort of highlight some of the misinformation. Has been astonishing in my mind. And hopefully as we move forward, we will look in Canada and perhaps here in New Brunswick as a place where we try to address many of these issues as best as we could. So I think overall, while we've done some things well, I think there's some observations that are worth mentioning in my mind that are worth focusing as we're going to be in this for some time. And the first one is around coordination of screening and standardizing our precautions and those type of things. While we've done reasonable in the hospital, there's been tremendous variability in our approaches and various floors, various locations, and various places that I think would have benefited much more from a unified approach, but unfortunately that did not happen. And while it's becoming much more unified now as time has evolved, the likely reason it's becoming more unified is partly because the pressure and the stress around the COVID-19 in our province is less. If we were much more under pressure, we would be so much more dependent on being more unified around that. And that's something that I really would like to strive to, and I really push, and the last point here will push to that. It's incredible. I chat with Ansar once in a while. It's like everybody's become an infectious disease specialist nowadays. It is incredibly frustrating because there are things I can't answer and I don't want to answer because I don't know the answer perfectly, and that's why we have some specialists, and we need to follow their guidance, and their impression are critical, and sometimes we have not. I think the institution has tried their best to do certain things, but the pace of implementation or asking for certain issues has been really, really slow to do. And I don't know how to change that. While it's probably moved a lot faster than it's used to, I still think we do things too slow. The particular example that I'm thinking right now is that everyone agrees that Prince Edward Island patients coming for cardiac care, which represents about 10% of our population, does not need to follow the current precautions, potentially of basically labeling them as possible COVID patient for a period of 2 weeks, regardless of testing or screening, in a province that is behaving the same as us. And it doesn't matter how we try to explain or try to the potential impact and potential impact on patients themselves, it is still not reached a point where we can adapt and change that to treat them like New Brunswick patients. I hope this will change soon. I think communication is critical, and hopefully these types of rounds and gatherings are really helpful for us to do this, and communications helped us do this, and these platforms are helping us do this. But the reality of communication is ensuring that it happens, and I feel, for example, right now I'm giving rounds to my screen of my computer. So it's actually quite hard to get feedback from all of you. So it's actually hard to get that aspect, and hopefully we can work out ways to do that better. I think leadership is key, and leadership goes on so many levels. We need to be leaders in our institution, in our province, nationally. I think we have lots to contribute. and we've been lucky. The Heart Centre and Ansar has pointed out, certainly the cardiac surgical group has been heavily involved in the national landscape in terms of modeling and trying to, how do we address this crisis? How do we deal with the issues? How do we set guidelines? How do we do this nationally? And we'll continue to do so. And we've had some tremendous success also internationally by being part of the Society of Thoracic Surgery in the United States. So we've actually collaborated with them on several aspects of this, which has been a great experience. So what does this mean going forward? This was a great meme that somebody sent me. Here's a chokehold by Darth Vader, pre-corona choke. Now we do with social distancing. I hope that we can adapt a little bit in our institution. We still have issues in terms of learning how to function. We ask restaurants and we ask bars and we ask, the grocery store to be careful, but then we come to hospital and are not necessarily careful about the social distancing and wearing masks and those kind of things. The reason we're trying to do it is really to be ready for the next time. And that's something I think we need to remind ourselves. So in conclusion, I think COVID-19 will have an impact that will last. There's no doubt in my mind. And that also means that this is a great opportunity to do things differently and better. How many times in our lives have we had a chance to put a reset on every single thing that we do? And we currently have that chance. And we've taken that chance to heart, for example, with these rounds and the way we do things clinically. I think we need to remain vigilant and be ready for the second wave because it will likely happen. Will it be the same way as the first wave here in New Brunswick? I have no idea, but I'd like to be ready. And finally, data, I think, is power to guide our responses going forward. And this is why I wanted to show you a little glimpse of the data that we have available here in New Brunswick. And that's really the type of effort that we're trying to do nationally, that my colleagues across the country can actually have this type of data and we can share it nationally, that we can actually share our experiences and then guide our responses. Thank you very much.
Thank you, JF. That was great. Questions for anyone, please use the chat line. That would be wonderful. But that was a great talk, JF, and a great reflection. And we've got a few minutes. Quick questions. And first, I'll just start with a housekeeping comment, just in case people leave a bit early or have to go back to work. First things first, number one is that next week, our talk will be given by Dr. Sorab Lechmedial, and it will be specifically about MitraClip. Its indications, the kind of patient population that we hope to see undergoing this procedure, and some of the echo guidelines for this particular procedure. So that's next week. Second, I'd like to welcome cardiologists from across the province. We have now officially invited people, cardiologists and internists from Moncton, from Fredericton, and from Bathurst. And then next week we'll add the Miramichi, and as far as we can go, we'll keep adding. Quick question, JF, with respect to the wait list management. During this time, and I guess in general, there was a question as to, how we all have differing wait lists in terms of length and the kinds of patients. Is there a concerted effort amongst us to share, other people's lists so that, we can decrease the wait time for long waiters?
Yeah, good question, Ansar. It's something that we've certainly talked about many times. In principle, we have in writing that after 90 days of wait, we would ensure or try to reallocate certain patients to different surgeons. So we've had that discussion, but that discussion always has to be initiated by the surgeon who has that patient. So it's really upon us, I think, in some ways to facilitate that. When patients have issues or problems get admitted, there's really no issues from that point of view because the urgency becomes higher. And I think all of us are generally willing to do other surgeons' patients if they're in need. I think there's really room to improve a little bit how we do that, no doubt.
And then the second question is just around preparing for the second wave. So you kind of indicated in your last slide that this is something that we should be constantly, aware of. And how do you just maybe give me a couple of examples of what you see us doing, even right now, as we start to prepare for that second wave? Because obviously there is a desire amongst everyone in the public to kind of move from one color to the next and hopefully get ourselves to green. And but at the same time, everyone's a little bit nervous, whether it be sending their kids back to school, whether it be reopening of businesses and going back to, restaurants and all of that. there is a certain anxiety in the air as to where this is going to go, and you can hear it. You can hear the chatter that, you know, well, really not much is going to be open in September. It's hard to believe that looking outside now, but what are we doing here, like at the Heart Center specifically, that, you know, you think is preparing us for that second wave?
I think one of the things that we're trying to prepare is again educating all our nurses and our frontline staff in terms of screening, includes our secretaries when they call patients. I think being vigilant from the get-go in terms of screening of people is still going to be the primary way we're going to identify potential patients at risk, especially when you're going to start having some infections. The second part is really trying to really encourage all our colleagues to try to practice safe distancing. And I've noticed over the last few days and few weeks is people are a little bit more careful about wearing a mask when they're around each other if they can't practice safe distancing. That's something that I didn't see 3 weeks or 4 weeks ago, which is interesting. So I think we're doing that better. I think the data that I showed you is also a critical way for us that now we may not need to shut down completely when the pandemic or when the case numbers start, because we know we can ramp down very quickly. I think there'll be an ability to be a little bit more strategic in how we do things and not allow full complete shutdown immediately, while we can still provide service and avoid over a month period losing 66 patients who would have benefited from intervention. So those are the three main parts in my mind that we need to focus. The other parts are really trying more for the institution to operationalize a little bit more their streaming of patients. How do they come to clinic? How do they not wait in line? How do they not wait in the waiting room? All those kinds of things. And even those aspects are part of the discussion that, as I met with someone this week, is the potential aspect of that will include providing masks to patients when they come in if they don't have them. So you don't have to necessarily social distance in the clinic space, but you'd be able to sit next to each other but have a mask wearing. So there'll be a lot of these things are going to change over the next few weeks, I think.
Yeah, agreed. Well, I think on that note, we've hit the 8:30 mark. Thank you so much for that enlightening reflection. I think this is something that, you know, we shouldn't forget about just because things feel like they're returning back to normal. There's a lot of lessons to be learned. I think to reiterate something you've already said, I'd like to thank not only everyone on this line, but just in general. I think there were so many people who put themselves out on the front line, and I know that term gets used loosely, but it's true, during this time, who, you know, we may not have had the cases that we've seen in other provinces or other jurisdictions across the world, but, you know, people were here and willing and able and ready to work and put themselves, you know, potentially in jeopardy. And I think that speaks, you know, to our unit and to our heart center. So with that, I'd like to, you know, conclude, and thank you, JF, and we'll see you all next week.
Thank you.
Thank you.